So she's making two words?
What did he say?
So she's making two words.
Oh.
So we'll see how much you guys remember about the abdominal wall.
Jeez.
Oh, yeah. So it's been a while, right? So we'll talk. This isn't going to be as intense as one of your anatomy lectures. We're going to talk a little bit about referred pain patterns and things like that, which are kind of good to see if the patient's hurting in a particular area, what it could possibly be. Sorry, bring this up a little bit. All right. So when we look at the abdominal wall, when we first look at the abdomen, there's going to be definitely some surface features that we can palpate on there. And you can see the surface anatomy of the abdomen is going to expand all the way down here from the xiphoid process, and you can feel the costal margin as well, all the way down to the pelvis area itself. And there's going to be specific landmarks on the hips and pelvis that you can also palpate in order to get your orientation and which vertebral levels that you're actually going to be at. But the pelvis itself, remember we've got three fused bones, ilium, pubis, and ischium. And there are certain landmarks on these bones that are going to help you find particular structures and make sure that you're in the right area. So when we look at the landmarks associated with the ilium right here, iliac crest can be palpated definitely on the sides, right? ASIS, so you can palpate definitely the ASIS. And you can also, on the pubis bone, palpate your pubic tubercle as well as the pubic symphysis. And remember the structure that runs between our AS and our IS and our pubic tubercle. What's that going to be? Yeah, inguinal ligament going on down there, okay? Yeah, inguinal ligament, okay? So there are a lot of these landmarks that you can utilize to palpate and make sure that you're targeting the right structure in the particular area. Also, when you look at the surface anatomy of the abdomen, remember that the umbilicus in a physically fit individual should be approximately at the L4 vertebral level. However, you can see based on body habitus that it could be a little bit more inferior or more superior, just depending on the body habitus of that patient. And when you're at the L4 vertebral level, you're also going to be at the T10 dermatome level. Okay, so remember the umbilicus is going to be right there, hanging out in your T10 dermatome level. You can also draw some planes through the abdomen to divide it up into quadrants. And when you divide these quadrants up by the median plane, which you can see here, and then the transumbilical plane, which goes right through there, you can divide it up into the four quadrants, RUQ, LUQ, RLQ, and LLQ. And those are typically going to be described for locations in which certain organs or structures are going to be located within. You can further subdivide that into the hypogastric, epigastric, and others, so make up 9 of them, but this one's just a little bit more in general right here. If you look at other planes that are going through the abdomen, you can see the L1 transpyloric plane. It's so named because it will go through the pylorus of the stomach, as well as the superior or first part of the duodenum right here as well. So the structures along this plane right here, typically at the L1 vertebral level, will target the pylorus of the stomach. It'll go through the body of the stomach as well on its way through. All right, so now let's look at some of these fascial layers of the abdomen. And we'll start going superficial to deep. So start with the skin, and then right underneath that, you can see the Camper's fascia right there. And this is where you're going to see a lot of your superficial vessels running in this layer. On the deep surface of the Camper's fascia is the Scarpa's fascia, which you can see here indicated by this purple line right here. So it's the deep membranous layer of that Camper's fascia right there. And then when you go deep to that, you're going to run into the external oblique muscle, then the internal oblique, transverse abdominis, and then the transversalis fascia. What's not shown here also is the rectus abdominis, which will be just a little bit deep to the external oblique, and about on the same plane as the internal oblique, but it'll be wrapped in an aponeurosis, which we'll look at in just a moment. So as we go from external to internal, we'll look at these fascial layers, so you'll know exactly what you're passing through if you're going to do any type of incision into the abdominal wall. You can see here, this is just a longitudinal section right here. So we've got the skin, we've got the camper fascia going right here. The scarpa fascia is represented by this gray line right here. And then we've got some of our oblique muscles right here, okay? So external, and then we got internal, and then the transversus abdominis. Deep to that, transversus abdominis, you'll find the transversalis fascia right here, and then you'll see some extraperitoneal fat, and then the parietal peritoneum finally, before you get into the peritoneal cavity right there. So you can also see between each of these layers, there's some investing or deep fascia, which kind of separates those, and it'll create some of the demarcations that we'll see on the rectus abdominis muscle momentarily. What you can also see, though, is that we've got these deep membranous layers right here of the scarpa fascia. It's going to come here and attach to the pubis bone. So what this is going to do is I'm also going to create two different cavities. So things, infections, things like that occur in the abdominal region don't spread down into the thigh region because it's actually connected to the bone right here. And the thigh fascia will be a little bit continuous with it, but the bone is going to separate those two pieces from each other right there. Within the peritoneal cavity, we do have some omenta. We have the lesser omentum and the greater omentum. Within the lesser omentum, you have your hepatoduodenal ligament right here, which a portal triad will be traveling within. And then the greater omentum, which is going to be kind of like this flap coming off the greater curvature of the stomach right here, covering the intestines. And what you can see with the greater omentum is that you can get adhesions actually forming. They can form on the wall or peritoneal cavity, wall of the peritoneal cavity itself, or they can go and form and wrap around. For instance, you can see right here, we have a wrapping around the appendix. And if the appendix is inflamed, typically you can hear the term that this appendix has been walled off right here. And that will be due to the omentum wrapping around it and trying to keep it from, if it does burst, releasing the contents into the abdominal cavity itself. But anytime you go in through any laparoscopic procedure, you are going to initiate an inflammatory response when that wound tries to start healing. And that inflammatory response can sometimes be picked up by the omentum right here, and the omentum can cause an abdominal wall adhesions as well. Yes? Yes. Mm-hmm. Yes. So anytime you get any mobility that's sticking to the abdominal walls right there, these adhesions will cause problems in mobility. Yeah. So it'll be pretty painful as well. But like I said, you run the risk of that anytime you go into the abdominal cavity because of that inflammatory response that's initiated by those trocars and things through. All right, so looking at the muscles themselves, you can see these layerings of muscles and how they're kind of oriented toward one another. A little bit more superficial, we see the external oblique with the big aponeurosis right here. And then deep to that, we can see the internal oblique, rectus abdominis, and then transversus abdominis will be deep to that. So these are going to be the major layers right here. And here you can see just going from superficial to deep as well. Again, the orientation of these oblique layers right here. External is going to be more superficial. The rectus abdominis and internal oblique are going to be almost on the same plane in the midpoint between external and the transversus abdominis. So just going from superficial to deep, you see these different layerings of the muscles themselves. The rectus sheath, remember, we are going to enclose our rectus abdominis muscle within this rectus sheath. And this rectus sheath is actually going to be a contribution of many different layers, as you can see in the image right here. So when you see the rectus abdominis, what you can see, depending on where you're at, because remember we have an arcuate line on the abdominal wall. Depending on if you're above or below the arcuate line, you're going to get changes in the aponeurotic sheath that is binding around the rectus abdominis muscle. So if you're, in this instance right here, we would be above the arcuate line in this area right here. And what you can see here, the rectus abdominis muscle is going to be wrapped on both sides by a portion of the external and half of the internal oblique muscle sheath. But the internal oblique is going to split into two, and then it's also going to go posterior, and then you're going to get the transversalis right here as well. So you can get the aponeurotic sheaths formed wrapping around the rectus abdominis pretty tight around both sides, giving you a lot of stability to the abdominal wall in the more superior aspects of the abdomen. So here's just another view of the rectus sheath here. Another structure you may see is this linea alba or midline indentation going all the way up from the xiphoid process down to about the pubic symphysis, and the umbilicus should be running in this. But you also see these investing fascial layers that are going to create this quadrate muscle appearance of the rectus abdominis, and that's how you get your six-pack appearance in your abdomen region right there. But like I said earlier, it depends on if you're superior or inferior to this arcuate line right here. So we already looked at the structure superior to it. The rectus is going to be bound on both sides by aponeurotic layers. But here, when you go inferior to the arcuate line, what you see is that all those aponeurotic layers are going to be anterior to the rectus abdominis muscle. And posterior, what you see back here is just a layer of transversalis fascia, and then you can see that extraperitoneal fat, and then the peritoneal cavity itself. So you get a little bit of support anterior right here, but not much support posteriorly to this when you're below the arcuate line. So this is going to be an area of susceptibility to herniations as well in this region. All right, let's review a little bit about our abdominal wall nerves. Remember that when we look at our spinal nerves, they are going to angle a little bit anterior-inferiorly as they move and wrap around the anterior surface of the body. So these aren't specifically going to correspond to the exact vertebral level. But what you see on the anterior surface, you see T1 to, or T7 to T11 are intercostal nerves right here. And then subcostal would be T12. And then we've got our iliohypogastric and ilioinguinals down here, branching from one of the L1 branches. But what you notice is that, for instance, your T7 spinal nerve right here, that should correspond also, your T7 vertebral level is going to be the inferior angle of the scapula, okay? So we have a little bit of discrepancy. Also, when you look at T10 spinal nerve, it's coming down toward the umbilical level right there. But if you look at the T10 vertebral level, you're going to be at approximately the base of the heart, or the inferior border of the heart. So make sure you remember, there's a difference between where the vertebrae is and how these spinal nerves actually angle and they wrap around the body as they move a little bit more inferiorly to their actual vertebral level. All right, let's look at a couple of the arteries that are going to supply the abdominal wall. So with our internal and external obliques, we can see a lot of these arteries are going to be supplied on the lateral aspect by these posterior intercostals, or our subcostal arteries, which are going to be branching from the aorta. Hi, you're late. All right. So superior epigastrics right here. So superior epigastrics, where are those guys coming from? Where do you remember our superior epigastrics are coming from? No. Oh. We'll try internal thoracics, okay? All right, let's try that one out, all right? Those go along both sides of the sternum. They continue on and give off the superior epigastrics. Your inferior epigastrics, where is it coming from? Yeah. External iliac right there. And then our superficial epigastrics, where are those coming from? Femoral, okay? So the superficial epigastrics will track up through Camper's fascia. The superior and inferior epigastrics are going to be posterior to the rectus abdominis within the rectus sheath. Okay, so if you reflect the rectus abdominis muscle on that posterior aspect within the sheath is where you will find your superior and inferior epigastrics. And remember, those can actually form anastomosis with each other. All right, so here you can see some of the venous drainage right here. We got our superior epigastric veins going up here, and they're going to drain into what? Besides before that. Internal thoracic veins, and then they're going to track back, right, to the superior vena cava. Our inferior epigastrics, they're going to drain into the inferior vena cava right here, so we have caval drainage in these portions right here. And then our superficial epigastrics right there are going to drain down here into the femoral region, okay? But make sure, like I said, most people confuse the superficial and the superior epigastrics, and those are in two different planes of section because you can see right here in the rectus abdominis muscle has been cut. So when you cut that open and look on the posterior aspect of it, you see these venous structures. But what you see with your superficial epigastrics, they're right here hanging out in the Camper's fascia, right there. So they're going to be more superficial. And you can also see them being distended, for instance, which we'll look at in just a moment. So if you do have interaction between the superior and inferior epigastric veins, you will get a caval anastomosis going on right here where things are flowing either back to the superior vena cava or down to the inferior vena cava to get back to the heart. What happens when we get blockages though? So when you get blockages, then you're going to get a rerouting of this blood. And these are still called caval anastomosis because you're rerouting. For instance, if you have a blockage that's preventing you from dumping into your superior vena cava, you're going to reroute the blood and go back down to your inferior vena cava. And then that will ultimately get back to the heart. Or if you have a blockage of your inferior vena cava right here, you're going to reroute the blood and it will go back to your superior vena cava. And it can take either a superficial or deep pathway to get back to where it needs to go. So for instance, if your superior vena cava is obstructed, the superficial pathway that the blood would actually drain through is the internal thoracic vein all the way back down through the inferior epigastric vein to get into the inferior vena cava ultimately. And that's mainly one of the things that you can look at. You can also see there's a lateral thoracic vein which will drain to the superficial epigastrics. So actually this one will be a little bit more deep than this one right here. So this one will be more superficial on this side right here. But you can see you can utilize the same pathways if your inferior vena cava is obstructed. Now what's going to happen is that those vessels are going to dilate larger than they normally would because they're carrying a larger caliber of blood. So they may not be able to reroute all of it, so you may be seeing some pooling of that blood in particular regions of the body as well. If you have an obstructed inferior vena cava right here, what you can see. Now sometimes they can be obstructed due to tumors, sometimes during pregnancy, things like that. But you can see some of these more superficial veins also being distended where the blood's trying to actually route back up and get to the superior vena cava in this caval anastomosis. Now remember, we also have a portal caval venous anastomosis, and one of the first ones we see is around our paraumbilical veins. So those paraumbilical veins are going to typically drain to the liver, and those are also going to be located within the Camper fascia as well, and then they're going to interact with those superficial epigastric vessels. So what you see, if you have the interaction between these two vessels, the paraumbilical veins drain to the liver, superficial epigastric veins drain to the inferior vena cava. But what we know is that if we do have something going on that is creating portal hypertension, or if we're having any cirrhosis or anything like that, or stenosis of the portal system right here, what we do is back up the blood, and it has to go somewhere else. Okay, so if you can't get enough blood tracking through the liver to be detoxified, what you can do is you can back up through the paraumbilical veins which is going to be very, very superficial, you will interact with the superficial epigastric veins, and then you'll ultimately dump into the inferior vena cava to get back up. But this means that if you have a high backup of blood flow right here, that you may not get all that blood detoxified as well, because then it will go onto the inferior vena cava, up to the heart, and then it'll go out through the system right here. So one of the things you may see on your patient is a caput medusa if they have some sort of blockage where it's causing a portal cable anastomosis right here. And here's an image of what you can see of these superficial epigastric veins being actually distended a little bit. As that blood flow tries to track back, those veins will dilate out, and then it'll try to get back into the inferior vena cava in that region. All right, superficial lymphatic drainage. So when we look at the lymphatic drainage, it's pretty cut and dry in this region, especially when we're talking about superficial structures. And we're looking at it in terms of relation to the transumbilical plane right here, which in this image it's not actually going through the umbilicus, but it should be, okay? So when you're superior to that, you're going axillary, depending on which side you're actually on. But you're going to drain to the axillary lymph nodes. And if you're inferior to that, you're going to drain to your superficial inguinal lymph nodes. And then those superficial inguinal lymph nodes are then going to drain to the deep inguinal lymph nodes, which will then go and carry all of that lymphatic drainage up through the thoracic duct and then into your left venous angle, where it can then be recirculated into the system. All right. So now other structures associated with the anterior abdominal wall. Right here we have the inguinal ligament. Okay. So the inguinal ligament is going to span all the way from the pubic tubercle to the ASIS, and it's going to be in the inferior border of the external oblique aponeurosis right here. So here you can see the external oblique aponeurosis, and here's where you can see this most inferior margin of it right here. That's going to help form that inguinal ligament right there. Okay. Right, just superior to that inguinal ligament, you will have this oblique inguinal canal, where your deep and superficial rings do not overlap, and that's going to allow for some stability of the external surface of the abdomen right here. But what you can see is the inguinal canal forming right here, and this is going to be partly due to the fact that we need to get the testicles down to the right location after development. Also, that we're going to have the some of the structures of the gubernaculum of the ovaries going down to the labia majus in this region as well. But what you can see here, it's going to depend on, when we talk about inguinal hernias, if it actually traverses through the canal, or if it's going to be going through the canal, or if it's just going to come right through the wall itself. So as you can see in this image right here, what you can see, this would be a male where the spermatic cord is actually coming through the inguinal canal right here. And we'll look at that in a little bit more detail. Because when we look at male inguinal canal development, the inguinal canal is a lot larger in the males, because you have to see right here that the testicles are developing in the posterior abdominal wall. And in adult males, we see that that's not where they stay, right? Okay, so they actually are headed for the scrotum. They have a gubernaculum right here, which is going to attach to the inferior pole of the testicle, and then attach that to the scrotum and pull it on down. Now, as the testicle descends through these layers at about 9 months, you can see it's almost at its final destination right there. It is going to drag with it all of its nerve supply, blood supply, venous drainage, and vasculature. So everything's going to be dragged down with it, and that's going to help form the spermatic cord. Okay. So here you can see the spermatic cord in the male. It's going to be a lot larger in caliber than what's going to go through the female inguinal canal. And this is why some males are typically more prone to herniations right there in that region. Females, you might see a little bit more herniation below the inguinal ligament at the femoral triangle area. You can get femoral hernias. But when we look at the layers that you have to penetrate through when you're actually traversing the inguinal canal in the male, you go through the transversalis fascia. You also go through the transversus abdominis muscle, internal oblique muscle right here, and then through the external oblique aponeurosis. So you're traversing through all of these different layers to get out to the exit or superficial ring right here, and then head down to the testicles themselves. In the female, we still have those gubernaculum, which are going to move the ovaries just a little bit from the posterior abdominal wall. However, what we see is those gubernaculum turn into the ovarian ligament right here, which hooks the inferior pole of the ovary to the uterus itself. And then we also have another portion of that ligament which will turn into the round ligament, which actually connects between the uterus itself. It goes through the inguinal canal and connects to the labius majus right here. Okay, so you can see you've just got a round ligament, and it's quite, like I said, quite smaller in caliber compared to the spermatic cord going through that canal in the female. So here you can see the contents of the inguinal canal in the male and the female. Basically, what we see here, we've got that ligament right here, the round ligament, and then in the male we have our spermatic cord. Now we also have some nerves, which we'll talk about right here. Ilioinguinal nerve, which is going to give you some sensory information to the genital region down here. And then also the genital branch of the genitofemoral nerve, branching from the L1, L2 spinal levels. And that's also going to give you some sensory information coming from. It's going to relay sensory information. But this nerve is also going to go to the cremaster muscle in the male, which is going to wrap around that spermatic cord and allow for some elevation of the testicles and heat regulation. Right? So when the heat changes, the testicles either ascend or descend. Typically, they're cold, they ascend. Too hot, they drop a little bit. All right. Now herniations, when we look at inguinal hernias right here, they come in two different flavors, and they both have two different names. We've got direct or acquired, or indirect and congenital hernias right here. So what you can see in relation to the direct or acquired hernias, they will emerge medial to the inferior epigastrix, which you can see right here. Okay, so here are the inferior epigastric vessels right here. They will enter into the canal via the posterior wall, so they won't go through the deep ring. They go directly into the posterior wall of the canal, and these typically do not go into the scrotum. All right, but if you're looking at indirect, these are actually going to be also called congenital hernias. They are very common, or more common than these direct ones. They enter laterally to the inferior epigastric vessels here, which means that they will enter into the deep ring. Okay, so if you go lateral to the inferior epigastrix, you're entering into the deep ring. You're traversing the canal instead of busting through the back door of the canal right there. So as you traverse that canal, you're also going to go through all those different layers we talked about that the testicle has to go through to get out. So that means you're going to drag those fascial coverings with you as well. You're going to exit out the superficial ring, and then since that's the same route that the spermatic cord took, and you're wrapped in those fascial coverings as well, you may go into the scrotum or labia majus right here. So here you can see some of that portion of the intestinal loop actually wrapped in the same coverings that the spermatic cord is wrapped in, so you can go down into that region of the testicle. All right, so now let's talk a little bit about some patterns of referred pain, and these can be very, very important in helping you to diagnose or figure out what these underlying causes are. And the patterns of referred pain are they can be kind of different from person to person, but we do have this generalized kind of consensus on where some of these patterns of pain actually reside. So if you start here, and we'll look at foregut, so we'll start with the esophagus right here, okay? And when the esophagus comes through the diaphragm right here, sometimes what can happen is you can get some constriction in this region right here, or stenosis, and what will happen is you get clamping down on the esophagus itself, which can cause a portion of the esophagus to form this hiatal hernia in this region right here, or you can just clamp down on it and cause some backflow right there. But when you get this referred pain from the esophagus or this esophageal hernia, it will radiate out through this area shaded here in gray. Okay, so this looks, it can look very similar to other types of referred pain. You want to make sure it's not a heart attack. This person's probably just having some heartburn, reflux type things like that, but that can often get mistaken for Some people think they're having a heart attack, but they've never had heartburn or anything like that before, because you can see it will go in the same region right here on the anterior surface of the body. So mainly thorax, midline right here, sternal, and then it can radiate over here to the left side as well. And when we're above, so right here, when we're talking about referred pain, remember these signals have their own specific pathways to get back to the spinal nerves themselves. Since we're way above the pelvic pain line right here, these are going to follow your sympathetic signals back. Okay, so we're going to follow the sympathetic signals back to get to the spinal nerve. But then once it gets into the spinal nerve, spinal cord, your body's going to say, well, I can't really tell if this comes from a deep structure or superficial structure, so I'm just going to say it's superficial, and that's where it's going to determine that the pain is actually coming from. If you are below the pelvic pain line, you're going to follow your parasympathetics back for referred pain. So you can go kind of both ways, but the general rule of thumb is if you're in the thoracolumbar region where the sympathetic trunk is, you're going to follow that back. But if you are in the head, or if you're in the sacral area where you've got your parasympathetic cell bodies, then you're going to follow those back. You're going to take the most efficient route back to the spinal cord as possible. But it depends on which layer, which spinal nerve you actually go into to where that pain actually refers to. So other organs, we do have stuff inside the abdominal cavity, right? So we've got the stomach, and just a little bit of review of the stomach. Stomach, it should be hanging out over here in the LUQ, but it could be all the way down here, and it could cross over. So it's kind of variable depending on the position of the stomach. But what we see is the cardia, where the esophagus comes in, the fundus, or the more superior portion of the stomach, this large body, and then we've got the lesser curvature right here, where the lesser omentum will actually attach right there, and the greater curvature, where the greater omentum comes off. The pyloric portion, which vertebral level should we be at? The transpyloric plane, L1. Okay, all right, see, yeah. So it should go right through this region right here into the superior first portion of the duodenum. Okay. Also, other structures of the stomach, rugae, those will be more prominent when the stomach is empty. It'll look a little bit more smooth when the stomach is full of contents and dilated out just a little bit. So when you look at some imaging of the stomach right here, you can see some radiographic studies. You can see those rugae a little bit, the contours right here, as you see these imaging studies and all the fluid flowing from the stomach down into the duodenum itself. But also remember, you should see, if you do an x-ray, you should see an air bubble within the fundus of the stomach right here, which you can see, and that's due to the superior aspect of that. It's going to contain some gas in that region right there, so you'll typically see this air bubble. When you get referred pain from the stomach region right here, what you'll see is it will go midline right here, right beneath the xiphoid process, and also at the superior aspect of the costal margin. Okay, you can also see sometimes that it will refer between the scapula and the back right here, and this, like I said, can be variable between different people as well, though. The next portion, once you go through the stomach, duodenum right here, we've got several different portions of the duodenum. We've got the transverse, the descending, another transverse, and the ascending portion right here. And typically, what you'll see here is this is going to wrap around. These should be at about, like I said, the L1 vertebral level right here through the transpyloric plane. So you can see the duodenum is going to be over here in the RUQ mainly, but then it can cross over into the LUQ, like I said, just depending on the exact anatomy of your individual patient right there. And some of these are going to be mobile and some are not going to be mobile as well. All right. Wrapping around, so here you can see the duodenum right here. And within this inner curvature of the duodenum will be the head of the pancreas. Okay, so you can see the pancreatic duct coming in here. Also, you can see the bile coming in right there. And these are going to dump into the second portion of the duodenum. We're going to see those enzymes, or digestive enzymes, dumping in right there. And you can see the pancreas, it will span LUQ all over to RUQ as well. So we've got three different portions of the pancreas: the head, which should be right here, kind of the duodenum hugging it. The body is going to be posterior to the stomach, and then the tail is going to be pointed toward the hilum of the spleen, where those vessels are entering and exiting the spleen itself. Pancreatic referred pain. Now, what you can see right here, it looks very, very similar to stomach referred pain. So it's going to be in this midline region right here as well. So you may not be able to tell the difference between, is it stomach or is it pancreatic without doing further analysis on the patient right there. But what you'll see is it can refer to this region right here in gold. All right, the liver and gallbladder. So liver can span the RUQ all the way over to the LUQ. So it should be mainly in the RUQ right there, though. And remember, our falciform ligament is going to divide the liver into the right and left lobes right there. And then on this inferior margin on the anterior surface, you'll find the gallbladder poking its head out right here in the RUQ typically. This pain's a little bit different, referred. Okay, so once we can see liver and gallbladder. Gallbladder can be along the costal margin right here on the right side. So along the right costal margin, it should be pretty close to the costal margin, but it can also radiate down into more of the anterior abdominal wall area. But you can also get pain up here wrapping around the flank side as well as the shoulder region right here. And sometimes we also see this pain. But when do we also see pain in the shoulder region right here? What? MI, well, on the other side over here, females, it can go up to the jaw or the neck. But if you do, for instance, if you do any laparoscopic abdominal surgery, the comfortable gas right there, it can irritate your diaphragm, okay? And then that referred pain will go up through the phrenic nerve, and then it will refer out to the C3, 4, and 5 dermatome regions right here. But if you have inflammation of the liver, remember the liver, it has a bare portion on the superior aspect of it that's not covered with any sort of membrane or anything like that, and it can be right opposed up to the diaphragm itself. And if you get any irritation of that diaphragm, it can refer back up to this region up here in the shoulder. All right, other contents of the abdomen, small intestine. Well, you can tell a huge difference on these portions of the intestine if you're looking at imaging studies. For instance, if you are in the jejunum, you have these plicae circularis, which will give this feathered type of appearance with any contrast that's actually flowing through there. And that'll be due to the contrast flowing through this region where we see all these plicae circularis. But in the ileum right here, what you can see, you've got smooth contours of contrast flowing through, and that's due to lack or very sparse plicae circularis. And another thing you may see in the ileum itself is these pirate patches or aggregations of lymphatic tissue that's going to help try to kill off some of those toxins that you just ate with your favorite lunch. Small intestine referred pain, a little bit more inferior right here. Go toward a little bit superior to the umbilicus right here, midline, and it can radiate both sides right there. So those are just regions of small intestine referred pain. Moving into the large intestine, this one, you can see all the different parts here. Typically we have the appendix hanging off of the cecum right here, but this can be variable in location depending on the patient. Sometimes it can also be, the appendix can be retrocecal, which can be a problem when you're trying to diagnose an appendicitis. You see the cecum, the ascending colon. The ascending colon should be anchored to the posterior wall right there, so you don't have as much mobility and you don't get things being tangled up. The transverse colon will have a mesentery on it, which will allow it to be a little bit more mobile. The descending colon will be anchored as well. Your sigmoid colon will have a mesentery to make it more mobile, and then your rectum will be anchored. So we also have the splenic flexure up here in this region right here, and then our hepatic flexures right there between the ascending and transverse colon in this region. So when we look at referred pain from the colon, you can see it will be a little bit more inferior right here around the central area, probably around the umbilicus in this region. So Now what can happen is with appendicitis, you can see the variability in the positioning of the appendix itself. But typically what you'll see is some rebound tenderness at McBurney's point right there. But what will happen is that the pain will move depending on if it just started or if it actually inflamed the parietal peritoneum right there. So once you start getting initial pain from appendicitis, it should be diffuse around the umbilical area right here. And then once you get involvement of the parietal peritoneum, what will happen is that will become inflamed. The pain will become very, very localized, and it should localize to the right lower quadrant, depending on if your appendix is in this position right here. And it can also be localized to this point at McBurney's point, which is 1/3 the distance between your umbilicus and your ASIS. Like I said, not always will you push on that and then feel pain there because your appendix you may have some malrotation of the gut, or your cecum, your appendix could be retrocecal as well, and so it could be guarded from that pressure as well. So you can see the pain will start in this area, and then this will be a diffuse pain right here, but then it should be sharp and localized once it gets down to its final destination and starts irritating everything around it. The last thing, once you remove that parietal peritoneum, you can get into the retroperitoneal space and see the kidneys and your ureters as well. So here you can see those guys hanging out. And just some referred pain patterns from the kidneys and ureters. You see in this blue section right here. Typically flank pain right there with kidney stones, things like that. But if you do get a kidney stone, you can feel that thing moving all the way sometimes, depending on if you're lucky enough. All right. But you can see flank pain with kidney and ureter referred pain in the region of the lower back, flank, and it can go down into the legs or even into the genital area right there, especially if that stone is going through and moving out to the external surface. All right, so that's all I've got for you guys today. Anybody have any questions? No? I don't know if I will or not. The young class keeps me kind of busy. All right. Well, thank you guys.